Hello, everyone, and welcome to the TxRx Medications for Substance Use Disorders Echo. My name is Andrea Hebler, and I'll be helping to facilitate this conversation today as our wonderful facilitator, Angela Riley, is now with us. So hopefully I can do that, and if you allow me, I'll be helping in the conversation today. Nice to see you all, and I want to remind you first that this session is being recorded for later distribution, and it will be available at our Be Well Texas YouTube page. So you can go there and review the session anytime you want, along with many other trainings that we have there at our YouTube Be Well page. Before we start also, I want to remind you that the session, although it's being recorded, the information on the chat will not appear in the recordings. So we invite you to identify yourselves by adding your names, email addresses, and organizations. You will help us with attendance, but especially if you're seeking CMEs during today's class, we definitely want you to identify yourselves. Although if you're joining via phone, you may also send an email at cstat@utesca.edu so we can associate your phone numbers with your names. And today, in Today TxRx, we have Dr. Alicia Kowalchuk presenting the didactics, and then also she will be discussing a case during the second part of this session. And once again, we want to remind you that this echo space is the space of all teach and all learn. So we want to hear your perspectives and your ideas, especially during the case part of the class. So please feel free to raise your hands and take part on this conversation. These sessions are what we make of them. So welcome again to TxRx. And I think we're ready to start with some introductions. Dr. Waklu, welcome to TxRx. How are you today?
I'm doing fine, Andrea. Good afternoon, Siddharth Waklu, addiction psychiatrist at UT Southwestern. I'm the interim chief of the addiction division and the addiction psychiatry fellowship director. And welcome, everyone. Thank you so much.
Thank you, Dr. Waklu. Dr. Walker.
Hi, good afternoon, everybody. Crystal Walker, PA with a Doctorate of Medical Sciences, and I am currently the Director of Substance Use Treatment Services, both clinical and medical, for MHMR of Tarrant County.
Thank you, Dr. Walker, and nice to see you. Dr. Wims, welcome to TxRx. Do you want to introduce yourself to the group?
Sure. Thank you. John Weems here. I'm an addiction medicine doc here in Austin at UT Austin. Happy PA Week, Dr. Walker, and looking forward to the case, Dr. Kowalchuk, and the lecture.
Nice to see you again. And finally, Dr. Kowalchuk, our didactic presenter, if you could please briefly introduce yourself. And then I think we can start showing your didactics, and let's take it away. Thank you.
Okay, and I just wanted to shout out to Dr. Shorter as well. He's here from Menninger and Baylor College of Medicine, runs the Addiction Psych Fellowship as well, among many other hats. So thanks, I'm glad you're here.
I am so sorry,
No
Dr.
worries.
Shorter, that I left you out. Welcome to the session and nice to see you.
No worries.
Thank you for being here. Dr. Shorter, do you want to introduce yourself, please?
Oh, I'm Daryl Shorter. Like Dr. Kowalchuk mentioned, I'm here at Baylor College of Medicine and the medical director of addictions at the Menninger Clinic. Thanks.
Thank you. Welcome.
So I'll get started as soon as slides are up. I'm not seeing slides. Are anybody else seeing slides? Excellent. Great. Thanks. So we'll go through next slide. And I'm in the Department of Family and Community Medicine here at Baylor, and I'm medical director of Santa Maria Hospital, among other things. I don't have anything to disclose. These views, etc., don't express official policies of any of these agencies listed. Thank you. So our learning objectives are to identify SUDS or substance use disorders commonly seen in pregnant and postpartum women, describe some unique concerns of women with substance use disorders during pregnancy and postpartum, and some treatment for common SUDS that we might encounter with our patients. Next slide. So most persons who, once they realize they're pregnant, they stop drinking, smoking, or using. The big exception to this is cannabis, where 40 to 50% continue to use cannabis into pregnancy. So that is a big exception for us to be aware of, especially as cannabis use is increasing, particularly in reproductive age people. The consequences of early unintended exposure are most significant for the quote unquote legal stuff, alcohol and nicotine. And so I think that's important for us, particularly in the primary care setting, to recognize and screen for, because again, someone may not have a diagnosable use disorder, but presenting for prenatal care or even preconceptive care, using substance or multiple substances that may impact a potential pregnancy, etc. So the risk factors for not quitting when someone is pregnancy aware include having a diagnosed substance use disorder, so they try to quit and they can't. Severe psychosocial stressors, current and or past trauma is really high in this patient population, approaches 80–90%. And having severe mental illness and or developmental disability is also a risk factor to continue using substances once being aware of pregnancy. Nicotine use disorder, so this is not just use during pregnancy, this is diagnosed use disorder. Prevalence is around 4 to 7%. For cannabis, we do see increasing rates of cannabis use disorder in pregnant patients. There's a low perceived risk in this patient population for ongoing cannabis use during pregnancy. And so we see rates of around 1 to 2%. Alcohol use disorder and alcohol use during pregnancy is the most potent teratogen or substance affecting fetal development of the substance of misuse. But diagnosis of alcohol use disorder in pregnancy is less than 1%. It's around 0.3, 0.5%. So not insignificant when you think of this being, you know, one person every 200 pregnancies. And then stimulant use disorder diagnoses in pregnancy, those rates are increasing as well, especially for methamphetamine and other stimulants. There's a high perinatal morbidity with ongoing stimulant use in pregnancy, increased risk, and we'll get into this in later slides, particularly of hypertension in pregnancy, including preeclampsia, placental abruption, which is a big risk to the pregnant person and the fetus, etc., and even stroke. And stimulants rates are also less than 1%. They're around 0.3 to 0.4% for methamphetamine and for cocaine each. Opioids have the highest mortality when left untreated, and that's due to opioid overdose. And those rates in the pregnant population of opiate use disorder is around 1 to 2%. Next slide. So this slide is showing us statutes around the country in different states about notification and reporting policies on substance use during pregnancy. So one of the many barriers that pregnant persons face when they are thinking about or trying to seek treatment for their substance use disorder are legal ramifications and fear of legal repercussions. You can see in Texas, substance use during pregnancy is considered child abuse. And although we don't have required required reporting outside of delivery, at time of delivery. But still, patients coming in, clients coming in are very fearful about the legal repercussions. Next slide. So we'll go through some of the most common substance use disorders. We'll start with nicotine, which is the most common, and we want to not forget about nicotine. Impacts on pregnancy, primarily preterm birth and intrauterine growth restriction, low birth weight. Again, primarily intrauterine growth restriction here is restricted to birth weight or total weight, less about head circumference changes, which implies some neurodevelopmental issues, and less than some other substances on length as well, birth length. NRP or nicotine replacement products have not been shown to be effective for long-term cessation in pregnant women because nicotine can increase the risk of PIH, pregnancy-induced hypertension, and preeclampsia. It is a risk-benefit discussion to have with patients about short-term use for withdrawal management, right? So patients continuing to smoke nicotine are still at risk of all those things from the nicotine exposure. And so it is used, but we want to make sure we're doing that risk-benefit discussion. Varenicline and bupropion are not preferred in pregnancy. They can be used with risk-benefit, but behavioral treatments are favored for treating nicotine use disorder in pregnancy. Earlier cessation shows greater benefit, as we would expect. By 15 weeks, it gives us the most benefit to that pregnancy. And there's a QR codes throughout this talk for both patient or client and provider resources. This particular code takes you to Smoke Free Mom, a link to sign up for Smoke Free Mom, which is a text messaging program for smoking cessation in pregnancy. Next slide. So going to cannabis, we see impacts on pregnancy include preterm birth, the low birth weight. But in addition to low birth weight, we do see some changes on head circumference, decreased head circumference as well with cannabis use in pregnancy. There are no FDA-approved medications for cannabis use disorder. NAC has been shown to be effective in non-pregnant youth. There's not been studies in pregnant people with cannabis use disorder and NAC. Although NAC is considered safe in pregnancy, we don't have any data. NAC is actually recommended in several instances of high-risk pregnancy for other conditions. So it could be not unreasonable to consider that, but there is no data on that. Cannabis hyperemesis syndrome, the rates of that have been increasing, and that can overlap or be confused with hyperemesis of pregnancy. Hot showers, haloperidol, benzodiazepines are not recommended in pregnancy. And those are sometimes treatments that are either tried by the patient themselves or we're prescribing for patients with cannabis hyperemesis syndrome. What is safe or safer in pregnancy for dealing with hyperemesis of pregnancy, high dose pyridoxine, which is vitamin B6, metoclopramide, promethazine, although their efficacy for hyperemesis due to cannabis is less clear. Ondansetron, topical capsaicin have shown some benefit for cannabis hyperemesis, but they're really considered second line for treating pregnant women with hyperemesis because we do need to do that risk-benefit ratio, particularly for ondansetron, which has shown some signals for increasing birth defects, particularly when taken in the first trimester, which is when we often see those hyperemesis syndromes overlap. And there's a link about, this is really for patient information from ACOG, the American College of Obstetricians and Gynecology, on some facts around marijuana use in pregnancy on this slide for folks to check out. Next slide. So the impacts on alcohol on pregnancy, again, we see intrauterine growth restriction, low birth weight, also decreased head circumference, preterm birth, and increased risk of stillbirth. There's also an increased risk postpartum of SIDS. Again, this is our most teratogenic of the substances we'll be talking today. There's been no identified safe type, amount, or time frame for use of alcohol in pregnancy, and that's an important message to help to get out there and convey. Fetal alcohol spectrum disorders and fetal alcohol syndrome it can occur in the offspring of pregnant persons with alcohol use disorder that don't get treatment in pregnancy. It can also occur in people who don't stop drinking during their pregnancy but don't have a diagnosable use disorder either. So again, this is a public health concern. Rates of FASD in the community are estimated to be between 1% and 4%, which is very consistent with autism rates. So we don't talk as much about FASD and screening for and prevention, which we don't have a way, our single way of knowing how to prevent autism spectrum disorders, right? And yet, FASDs are preventable if there's no exposure to alcohol in utero, right? But we don't talk about that a lot, at least in the medical field. And so, again, thinking about alcohol when we're screening patients and taking care of patients in primary care that are of reproductive age and are at risk of pregnancy, and talking about that risk and helping them effectively contracept to avoid the risk or decrease or stop their alcohol use or both, kind of their choice. Treatment in pregnancy, medically managed withdrawal. We use diazepam or lorazepam. None of the benzos are really great in pregnancy, super safe, but we use a short course, and these are the two that have been the most well studied. Naltrexone and acamprosate, it's a risk-benefit discussion. They have traditionally not been considered first line. There's some more recent literature that suggests they can be considered for use for pregnant patients that are struggling with their sobriety despite behavioral therapy, which is the first line of treatment after medically managed withdrawal. We do want to make sure all pregnant persons should be taking a good prenatal vitamin that has lots of folic acid because that's really needful for neural tube development. But remember that people who are drinking alcohol, particularly heavily, such as people with alcohol use disorder, are usually engaging in heavy drinking. They often have a folic acid deficiency, and that gets passed on to the fetus and can make the risk for FAS and FASD in particular worse. So we want to make sure they're getting supplemental folic acid as well. And the link here is a CDC resource that has information for both patients and providers for digging further. Next slide. So the next substance we're going to talk about are opioids and looking at substance use disorder treatment in pregnancy for opiate use disorder. The impacts on pregnancy are primarily seen with untreated opiate use disorder and the stress that imparts on the pregnancy due to repeated cycles of intoxication and withdrawal. We see increased rates of preterm birth, low birth weight, and IUGR. Primarily, this is weight, not head circumference and length based. placental abruption, and stillbirth. Mood, our medication for opiate use disorder, is the gold standard treatment for opiate use disorder in pregnancy, full stop, with either buprenorphine or methadone. Methadone used to be the preferred agent, but now we have enough data and experience with buprenorphine and some of the studies that have shown perhaps some decreased issues with neonatal opioid withdrawal syndrome using buprenorphine versus methadone. And so now they're essentially considered equivalent, whatever's better for your patient in terms of them being able to practically access and continue and engage with that treatment and what works for them. Some of our patients that are using primarily synthetic opioids of high potency may or may not stabilize on buprenorphine, and in that case, we want to transition them to methadone, but either is fine. Naltrexone is generally not considered first line. Again, there is some movement toward incorporating that as part of the menu, but again, buprenorphine and methadone are what are first line. If you have a patient who's been maintained on naltrexone for their opiate use disorder and becomes pregnant, again, that is something to discuss risk benefit, but generally that can be continued into pregnancy. There are no signals in the research literature that naltrexone would be, teratogenic or cause developmental or other problems, but it's not something that we start preferentially in pregnancy. For buprenorphine and methadone, often we're needing to increase the dose, or particularly for methadone, split the dosing in third trimester because metabolism changes in the third trimester, as does just the total plasma volume. It's helpful to address upfront the stigma associated with taking mood in pregnancy, because it's real and it's out there, and it's often internalized by our patients. Also, what's out there is fear of neonatal opioid withdrawal syndrome. And so I think it can be helpful to share with patients that NOWS is not a universal event. Every person who takes buprenorphine or methadone during their pregnancy does not end up having their newborn in a NICU getting treated for NOWS. It is not a universal experience, and it's often, if it occurs, when it occurs, it's often manageable now without medications, and we'll talk about that later. We also want to provide overdose education and naloxone distribution to our patients, and again, we'll talk more in depth about that. And then there's some information for pregnant patients. There's a link to a SAMHSA fact sheet on getting treatment for opiate use disorder in pregnancy, and it really details pretty succinctly the benefits versus the risk of medication treatment with buprenorphine or methadone. Next slide. So stimulants. So stimulant use disorder in pregnancy, we see, again, that low birth weight, preterm birth, stillbirth, placental abruption, and then a lot of cardiovascular risk for the pregnant person, hypertension, preeclampsia, stroke. So this is pretty rough on the pregnant person. Again, there are no FDA-approved medications for treating stimulant disorders just generally, and certainly not in pregnancy either. Our go-tos are behavioral therapies like CBT and contingency management. And looking up stuff for this talk, I ran across a really interesting, fairly recent article on a contingency management program for perinatal SUDS that was started in North Carolina in the last few years, and they kind of gave some details about barriers and facilitators, et cetera. So maybe something that's of interest to our audience today, if you're looking to provide this for your patients and wanting to know maybe how to get that started with that. Or if you've started and you're having issues and wanting to see what other folks, how they've solved it. So Next slide. So I wanted to kind of just more broadly kind of back out from in particular substances and just think about the substance use disorders generally in pregnancy, in all phases of what we call peripartum. So prepartum, interpartum, and then postpartum. And so we'll start with prepartum. I've put a link to the Mommy's program from UTSA and from out in San Antonio. They developed this toolkit now almost a decade ago, but I think it's still very relevant. The toolkit really highlights that it's to help decrease nows, but really it really does so much more than that. Because you really have to, right? When you're taking care of a pregnant person with substance use disorders, there's a lot of things to consider beyond fetal development and focus on the fetus and the outcome for that child, that newborn, obviously the mother, that pregnant person, and then all the things surrounding to support that dyad. So it's really important to engage the person with substance use disorders who's pregnant in high-risk prenatal care. So this is a high-risk OB referral where available, because I know not everybody has high-risk OB easily accessible, very as early as possible, and keeping that person engaged, continuing to go to prenatal appointments. Ideally, that prenatal care provider, and sometimes we are living in a nice ideal world. I get to do that here, which is really lovely. Sometimes we're not. But ideally, that prenatal care setting is trauma informed. They're not judging, shaming, and they're providing stigma-free care. Early entry into substance use disorder treatment, particularly if the patient is in active use stage of their substance use disorder. I also don't want to forget about those patients that have a substance use disorder and they're in recovery. Pregnancy is a unique stressor. And so we want to make sure that our patients, our clients that are in recovery and are pregnant are getting enhanced recovery support for that pregnancy and that postpartum period, because they are at higher risk of return to use and other sequelae. We also want to provide advocacy and education, advocating for our patients, and also providing that education largely to combat the stigma that's out there, particularly around medication treatment for opiate use disorder. Can't stress enough having family care plans and thinking again beyond just the pregnant person and or the fetus and the newborn, using shared decision making and keeping things patient-centered. So we want to make sure we have and are continuing to update throughout that person's pregnancy a care plan. How is that care plan helping support the patient staying safely housed? Having sufficient resources to maintain good nutrition throughout the pregnancy, helping with any legal hurdles they're facing, employment, other sources of income, etc. Next slide. So interpartum, one of the big fears pregnant people face going into labor who have substance use disorder is, how is my pain going to be addressed and effectively managed? They may have had prior experiences either with previous pregnancies or just previous painful medical events where their experience of pain was dismissed or not effectively addressed. And carrying that into that hospital, that labor and delivery floor with them. We want to make sure that their medication for opiate use disorder is continued interpartum. And then, again, pregnant patients with substance use disorders may find themselves very isolated from maybe prior friends and family that are not supportive of their recovery or are very judgmental. Maybe they're using themselves and they've made the difficult, but maybe necessary decision to step away from those folks in their lives to ensure their own recovery, or may be judgmental and shaming of that person in recovery and pregnant, and they're going in all alone. So it's helpful if that family care plan, if there are resources to ensure that person has a safe support person to help them through labor for coaching and partnering. And so again, I can't stress family care plans enough, so that'll be on the next slide too. And I've included here a couple of review articles, one written for nurses providing L&D labor support directly, and another written for prescribing providers providing intrapartum care on pain management of persons with opiate use disorder on the L&D floor. So folks can explore that further. Next slide. And now we get to postpartum. This should be postpartum. I'm sorry for that typo. So postpartum rooming in and skin to skin has been shown to decrease neonatal abstinence syndrome. So again, that's encouraging, mom and baby to really have a lot of skin to skin contact, laying the baby on their chest or their belly, just a lot of holding and cuddling, breastfeeding support when that's possible. It is safe. Breastfeeding is safe with both methadone and buprenorphine, so there is no contraindication to breastfeeding. As long as someone who presented for delivery, their substances that they were using prior to delivery have cleared, I'm talking about illicit substances, then it's okay for them to be breastfeeding. You want to make sure that that person is postpartum is getting continued treatment and support and postpartum follow-up. So that's a big one for us at Santa Maria, is making sure patients get back to their postpartum visit, which can vary from a couple weeks to 6 weeks, 8 weeks. Discussing contraception options, particularly long-acting reversible contraception or LARCs, and very important for postpartum depression screening, because people with substance use disorders and pregnancy tend to have a higher rate of postpartum depression. So we want to make sure we're screening for that for all people that are postpartum, but particularly in women with substance use disorder in the postpartum period. So when we see the highest rates of mortality from opiate use disorder in the peripartum period is postpartum, particularly when mood is stopped. And so that sometimes patients get disconnected from care postpartum, and that really puts them at a super high risk of overdose. Parenting support, developmental screening and early childhood intervention for that newborn. And again, can't stress those family care plans enough. I've left the link for Texas's early childhood intervention service webpage, homepage, and you can search from there for local agencies that do that work within your community. Next slide. We're almost done. And I do want to highlight overdose education and naloxone distribution. I think we're mostly all aware as people working in the SUD space that just about everyone now should have naloxone available and know how to use it. Folks are at risk even if they don't think they may be getting a substance that contains opioids. Maybe that's not what it's marketed at and it's containing some high potency synthetic and they're overdosing. So we want to make sure everyone has that, and that includes pregnant women. So overdose is a leading cause of perinatal associated death in the US, along with suicide and homicide. And it's especially prominent in the year postpartum, particularly when people disengage from mood. There's a lack of early discontinuation of recovery and parenting support. So again, those family care plans should extend for the full year postpartum. And we see when people don't have enough support, it's stressful being a new parent, right? For those of you who've gone through that, there's lots of increased stressors. There can be increased isolation from other adult humans, and lots of sleep deprivation, and all of that mixed together leads to some not great outcomes. We also see increased psychiatric comorbidity, especially postpartum depression, but other comorbidities can come up as well. I have included several resources for getting naloxone for free. One is naloxonetexas.com through UTSA. And the other, some people, especially pregnant, may feel weird or worry about being tracked, etc., whether they really need to or not, by accessing naloxone in a space where they have to put a name and an address. So you can also refer them, if you don't already carry it, just to be able to hand it to them as they come to your organization. You can refer them to a naloxone vending machine, and the statewide locator is linked to there. Next slide. References, and that's really it, I think. Yeah, thank you.
Thank you, Dr. Kowalchuk. Tons of great information here, so I'd like to open the floor for group questions. Anastasia, do you have a question?
I do not.
Oh.
Just clapping. It was a great presentation.
Oh, wonderful. Thank you. Thank you. Yes, we see a lot of positive reactions. Questions or comments from the group?
Hi, this is John. I wonder, Dr. Kowalchuk, if you could talk a little bit about Santa Maria. Here in Austin, when we have uninsured women with substance use disorder and pregnancy, often they're headed to Houston for Santa Maria. And I imagine other callers from other parts of Texas are in a similar situation. So I wonder if you could teach us a little bit. Thank you for a great talk.
Yeah, so we are, no, not every treatment program takes pregnant women, particularly for residential services. So we are one that does, and 94% of our patients are state funded for treatment. The other 6% have Medicaid because they're pregnant or postpartum. We have a great collaboration with our county hospital, Ben Taub, through Harris Health, high-risk OB program called the IMPACT Clinic. And we have parenting coaches that work at Santa Maria that are part and embedded with that program. So there's a lot of overlap in our programming. And the IMPACT Clinic provides a high-risk OB clinic for patients with substance use disorder who are pregnant. And when they come for their high-risk OB appointment, they also see an addiction psychiatrist who's a Baylor addiction psychiatry colleague, Dr. Avienda Ojeda. And so they get all those services together, and then they can also be in our residential treatment program, and we have parent coaches that work with those women and their families on those family care plans, pre, post, interpartum. The Bentob labor and delivery unit and the nursery. All of the pediatric staff in the nursery, the newborn nursery, as well as the OB, L&D nurses and staff have been trained around rooming in and providing support for the mother infant dyad. Lactation support is provided, etc. So women who go in to deliver there, who've gotten their care there, just really have a nice, welcoming, non-stigmatizing experience. A lot of that work jumped off from the mommy's work that was done in San Antonio a decade plus ago. So just kind of building from there and moving it to a new place in Texas, expanding it in that way. And so, yeah. We do also work with the courts in our area, the drug courts. And so we have a program called Women Helping Ourselves, or the WHO program, and that's for pregnant or immediately postpartum women who would have maybe had a jail sentence around a nonviolent drug offense, but instead we're giving probation with the stipulation that they engage in our residential treatment services at Santa Maria through the end of their pregnancy and postpartum as needed. Thank you.
Thank you, Dr. Kowalchuk. And yes, we have worked closely with the MOWI's program too, with Dr. Newton and the team, and they're great. They really provide great service, and they are great people to work with. So I want to see if any of you have any questions or comments. And if not, we will come back to some of this discussion, some of these ideas here, because Dr. Kowalchuk will be discussing the case as well. So some of this material will be revisited later in the session. So maybe we can move to announcements, and then we'll go to the case presentation. Thank you. And to claim your CME credits today, just text the code ATTEND 101-01074 to the number that you see on the screen. Please make sure that you're registered in the tax system so you can receive your CME right away. But if you have any issues with your CMEs, please send us an email here at CSTAT@UTSA or utesca.edu, and we can help you with that. But it should be pretty straightforward and simple. We are sharing the code with you on the chat right now. That's ATTEND 101-01074. Next. And remember that the Center for Substance Use Training and Telementoring, CSTAT, offers technical assistance. This is a free service for all of you in the community. If you need any type of assistance related to substance use disorders services, please go to our website and complete the TA form, and someone will get back to you in 1 or 2 days. Again, it's a free service, and we would love to see you using it more often. Next. If you have a case that you'd like to discuss with us here at TxRx, send us an email and let us know. We'll make it really easy for you. We'll give you a case form, and all you have to do is walk us through your case, and you'll receive expert clinical guidance, supportive peer learning, and evidence-based resources tailored to your case. The email to send your information will be cstat@utesca.edu. We'll hope to see you here in the next session presenting a case with us. Next. And we have the Texas Substance Use Symposium again on March 2 and 3. Please save the date. It's going to be at the Henry B. Gonzalez Convention Center here in San Antonio. Again, March 2 and 3. We're very excited with the convention. We'll see you there. Next. And of course, we'll see you again here in this space. That's next month, Thursday, October the 23rd at noon. We'll see you there. And I think we can start sharing the case form. And Dr. Kowalchuk, if you'd like to discuss the case, and then we're opening the floor for questions. Thank you.
So the patient is a 20-year-old woman who comes in with for residential treatment. She comes in already on methadone for her opiate use disorder, and she's G1 para0, so this is her first pregnancy. And questions that arose for me in this case and seeing her is, what are the best practices in managing co-occurring disorders in pregnant patients on mood? And what are safer meds in pregnancy for insomnia that's not responsive to sleep hygiene or behavioral interventions? She also has nicotine use. She vapes about 1 cartridge per month. Cannabis use started at age 13. Her last use was about a week ago. I saw her about a week after her admission to our residential facility in our eye care clinic, primarily around hepatitis STI screening for one of the programs that we run, SAMHSA funded programs we run for that. So she had stopped about a week prior to me seeing her. For her other substance use disorders, she has methamphetamine use disorder, first use at 16, last use was about a week prior when she was admitted, using a gram a day, no IV drug use. And then opioids, she had last used about 2 months prior, started use in her late teens. So her diagnosis include opiate use disorder, stimulant use disorder, and cannabis use disorder. And she reported being diagnosed previously with bipolar, ADHD, and PTSD. This was really her first treatment episode. She was already on methadone, 80 milligrams a day. She was on a daily pickup schedule because of ongoing use of other substances. And this was her first residential treatment experience. She was getting counseling through the program. She was really not interested in mutual support groups. She said she tried it once before, didn't like it. And she had some STI screening. She was in the process of getting set up with more formal prenatal care. We were just kind of seeing her for that initial visit into residential. Her aunt is in recovery, and her biggest support person brought her to treatment. The father of the pregnancy is incarcerated. She's estranged from her mother, no relationship with her father, lots of substance use disorder in the family. Again, unhoused when she came in. She was unhoused, couch surfing, so not living on the street, but not a stable place to live. She had had a job in food service a couple years before, but nothing long lasting. And only one suicide attempt in the past after a prior breakup. She just OD'd on everything, quote unquote. No findings on the PDMP. She'd been off psych meds for about 2 years. Previously, she was on Lamictal, Seroquel, and Adderall, and she liked being on those. She said they were helpful for her. Current symptoms, psychiatric symptoms, included racing thoughts, which were keeping her up at night. She wasn't sleeping well, and she was having a hard time concentrating in group in the residential setting. And so she wanted to start something for that. Again, current medications just included prenatal vitamin and methadone, and past medical comorbidities were asthma in childhood. But her last inhaler use was about little under a decade prior, and she'd never been hospitalized for asthma, no current symptoms of that. And so when I saw her, I was really doing kind of the medical piece and was like, okay, what do we use in pregnancy for bipolar? What could we offer her for ADHD? Do we offer her something for ADHD? What's her history? And how do we manage insomnia, which apart from other comorbid psychiatric conditions is pretty prevalent in folks with substance use disorder in early recovery, right? And that includes pregnant people. And yeah, so coming to the group for group wisdom, thankfully, the day I saw her, our addiction psych fellow was right next door, in the room next door. Dr. Shorter is smiling. So I went to Dr. Boss, Maddie, had some great advice. But again, bringing this to the larger group because it was a learning point for me as well. So thought it might be helpful to other folks to think about these things.
Of course. So let's hear from the group. Questions and comments.
Dr. Kowalchuk, outstanding presentation, and this is really a very complicated case that we usually see, people with such long histories of substance use. And the greatest challenge is how do we really tease out the diagnosis? And, such a long history of meth use, do they truly have bipolar disorder? They talked about ADHD. Is it truly ADHD, or is it a long-standing anxiety disorder that started in childhood? And so again, these are kind of diagnostic challenges and management challenges, and my approach to such patients is, and I would just kind of open it out would be probably starting a patient like this where there's not diagnostic clarity on a mood stabilizer, like not avoiding the mood stabilizers like lithium and valproic acid and lamotrigine. We would have to avoid those because she's pregnant. I mean the second generation antipsychotics like aripiprazole, that's the group I would go towards till I'm able to more kind of tease out the diagnosis. So that would be kind of the starting point that I would use. Yeah.
Yeah, I'd love to piggyback on Dr. Waklu, and I'll also say that this was an excellent presentation. So thank you for sharing today. Atypical antipsychotics, particularly medications like quetiapine, can be really helpful. And quetiapine in particular seems to have the lowest teratogenic risk among the atypical antipsychotics for treating bipolar disorder, if we truly believe that that is what is present. Lamotrigine may actually have a more a favorable safety profile, but again, we're talking about calculating the risks versus the benefits of that medication in the context of pregnancy. Lamotrigine, of course, would be really helpful for bipolar depression, but may not necessarily be as helpful or as effective as an anti-manic agent. When I talk to a lot of my colleagues that do reproductive psychiatry, we oftentimes will kind of go back and forth about the place of lithium in the context of pregnancy. We do know that there is a kind of small increased risk for the possibility of fetal cardiac malformations in that context. And so that's one of the things that you want to definitely balance when lithium is involved. And so to Dr. Waklu's point, going with lithium kind of out the gate might be considered a risk. And at the same time, if you have someone that was on lithium and becomes pregnant, taking them off that medication is something that really has to be sort of carefully considered, particularly if they've had a more moderate to severe course of bipolar disorder and they've become manic when the dose of their medication has either been reduced or certainly discontinued. So lots of different nuances when it comes to mood stabilization. When it comes to sort of the role of medications for insomnia, I think like you were talking about, much of what you kind of got, what was sort of suggested today was about behavioral therapies. And so gold standard, and this is true for someone who's pregnant versus someone who's even not in the context of pregnancy, is cognitive behavioral therapy for insomnia or CBTI. Finding providers that are actually able to do CBTI, that is the real challenge. And so we are up against knowing that there's a gold standard treatment out there in the treatment of insomnia, but also really struggling with this very limited resource with providers or practitioners who are able to provide that service of CBTI. So I just want to state that here for the group that if you have access to or are able to refer someone for CBT, specifically for insomnia, that would really kind of be your go-to first step prior to even thinking about medication specifically to treat insomnia. And at the same time, we have to recognize that insomnia can be a risk factor for mood destabilization, particularly in the context of the hormonal challenges that pregnant persons may be experiencing. So again, very, very complicated. We might be able to borrow from some of what we talked about already when it comes to bipolar disorder and bipolar depression in particular. Medications like quetiapine or Seroquel do have a sedating effect or sedating quality. It might also be a place to think about going if you believe that bipolar disorder and you're very concerned about insomnia. If, on the other hand, you're maybe a little less concerned about that, I mean, again, we're sort of outside of kind of our fully proven scope of safety, but things like melatonin might be an option for people. We've also got things like antihistamines, so your diphenhydramines or Benadryls, for example, might be an option as well. So all of these conversations, of course, have to take place with significant informed consent and a full discussion of the risks and the benefits associated with these medications, keeping in mind that untreated mania, untreated depression, and untreated insomnia, even in the case of pregnancy, do represent significant risks both to mom or to pregnant person as well as to the fetus. So thank you, Dr. Kowalchuk, for a really, really great talk and for this opportunity for us to think about what can feel very complicated for providers.
Yeah, thank you for all the input and the guidance. Really, really helpful and how to contextualize this. And then, beyond just Googling what meds are safe in pregnancy, what is actually needed. So.
I see a comment on the chat from Courtney. Courtney, would you like to unmute and elaborate a little bit more about that?
Oh, I think others covered it. I just was saying that I think the Seroquel would be great because it's fairly safe in pregnancy, helps with mood, probably help with insomnia. And then you've got just the monotherapy, which is nice.
I see. Thank you.
I would just push a little bit. I know we're not clear on diagnosis, but this person did report fairly early diagnosis of ADHD in late grade school years, and reporting that, that concentration in class and, not getting much out of it, was on a stimulant before for her ADHD. Part of the reason for ongoing meth use was that she gave was her ADHD and kind of aging out of having coverage for treatment. Any thoughts on that in pregnancy?
Yeah, so what I'll offer is, one of the things that I end up talking to patients and families and other providers about a lot is untreated ADHD can substantially sort of worsen one's ability to adhere to a recovery management or relapse prevention plan. I mean, it requires that you have a working frontal lobe and that you are managing your executive functioning. And so it seems that things like methylphenidate or Ritalin well, there may be a kind of a slight increased risk for perhaps cardiac malformation, spontaneous abortion, which is important to note that overall there doesn't seem to be any significant increase in major congenital anomalies. And so, again, kind of thinking through the risks and benefits of it. Is this someone who might be able to respond to behavioral management of ADHD? What does that look like, and where are we trying to utilize the sort of support regarding focus? So are we talking about someone who is actively in class or in school versus someone that might be in group and really trying to think through how to help them structure their day, and providing perhaps support along those lines can be very, very helpful.
Thank you, Dr. Shorter. And I think in the interest of time, we're going to ask Dr. Walker if she can give us a brief summary of some of the recommendations discussed today around our case. Thank you.
Absolutely. I'll try to be quick. I know we're at the top of the hour. So, Dr. Kowalchuk did an amazing, very rich presentation today where she went over almost all of the substances, major categories that you can encounter, and how to address them during pregnancy, from cannabis to nicotine to alcohol to opioids to stimulants. In addition to doing that, she gave us a ton of resources. That thing was chock full of QR codes. I love it. So lots of stuff to read up on. Be sure to check the iEcho chat or iEcho platform for all of those resources and her presentation, because there were some gold mines in there. One thing that she focused on a lot was family care plans. So if we take anything away from today, family care plans, very important. And this transitioned really well into her case presentation regarding a 20-year-old individual who has a history of using methamphetamines, nicotine, cannabis, and is currently on methadone 80 milligrams a day. A lot of discussion around her psychiatric care and her diagnoses of bipolar, ADHD, and how to treat those items. And as was pointed out by our experts on the panels, these things can, if untreated, lead to poorer outcomes. So making sure that those are addressed is incredibly important, including the ADHD, even if diagnoses aren't necessarily clear. Starting with treatment is going to be really important. Always, behavioral health is something to start with. CBT in the case of insomnia, ICBT, but these can be difficult to access for multiple patients. And so there were suggestions, of course, trying to really weigh risk versus benefit with a lot of the mood stabilizers. So going for safer medications like second generation antipsychotics or atypical antipsychotics is more of the first line. And then, of course, with the sleep hygiene issues, those can be barriers to get patients engaged. And if we want to go with medications, your Seroquel or even maybe some antihistamines or melatonin could be options as well. Again, very rich conversation, very rich presentation. Hopefully, you guys took lots of notes like I did, because it was an awesome conversation today. Thank you, everyone, for being here.
And I want to thank you and all of you for being here today. Please remember to answer that post-session survey. It's very short and it's a great help for us. So we'll see you next month in the same space. Thank you for attending and thank you for supporting the TxRx Echo series. Bye-bye.